the privilege and the pleasure to be with my friend Eveline Rieger as chairpersons in this session. But we also have with us distinguished colleagues as panelists, Dr. Hong, Dr. Hur, Dr. Castrati, Dr. Kubo, Dr. Lee, and I think that probably we will have with us also Dr. Rajagopal and Dr. Johnson. I think that I have mentioned everyone on board. So with this, Eveline, would you like to introduce the first speaker?
It's my pleasure to introduce the first speaker, Dr. Han-Soo Park. He will tell us about the short and long-term effect on cerebral embolic protection device on brain lesions following transcatheter aortic valve replacement, the Sentinel registry. Please.
Thank you. Thank you, kind introduction, Chairman. I'm Han-Soo Park from Asan Medical Center. I'm great honored to speak this study in this session. This study is about the cerebral embolic protection device during the TAVA procedure. This is disclosure. TAVA procedure can lead to cerebral embolization of debris. In AMC data, 30-day stroke rate about 2.8% and disabling stroke is 0.5%. The Sentinel trial confirmed the high capture rate of embolic debris and procedure safety for Sentinel device. However, protected trial showed Sentinel CP device did not significantly reduce the stroke rate. However, disabling stroke is benefit at the Sentinel group. One meta-analysis showed that despite the stroke rate are not differences between the Sentinel group and control group, disabling stroke and all-cause mortality have benefit in Sentinel device use. However, recent published large randomized trial protect TAVI trial, routine use of Sentinel CP device did not decrease the incidence of stroke rate within 72 hours, even in disabling stroke. So, in real-world practice, the protective effect of CP device and clinical outcomes remain controversial. So the aim of this study is to evaluate the procedure outcome of Sentinel CP device, focusing on the brain MRI imaging. From May 2022 to September 2023, we evaluated the patient with severe AS who undergoing transfemoral TAVA with CP device. The control group consists of enrolled patient of adapted TAVA trial, which compare the NOAC and depth to protect the protective effect of leaflet thrombosis. In this study, patient underwent TAVA without CP device. Serial brain MRI was performed at baseline and immediately post-TAVA and 6 months follow-up TAVA. And based on the anatomical location of the circular release, we divided the location to the protected area and partially protected area and non-protected area. Primary endpoint is the number and volume of new cerebral lesion at the immediate post-TAVA procedure. And secondary endpoint is the number and volume of new cerebral lesion at 6 months follow-up brain MRI and clinical outcome at 1 month. Final analyzed patient is 49 in CP group and 170 patients in control group. In baseline characteristics, male patients were more in CP group and APIP is more in CP group, and NOAC use is significantly higher in control group. Almost cases were used balloon expandable valve, and contrast volume is significantly higher in CP group. All cases are successfully deployed and retrieval of Sentinel device, and mean time of deployment is 26 minutes. The primary endpoint, the brain MRI imaging after the immediate after the TAVA, the new cerebral lesion and lesion number and volume were significantly reduced when CP device used. when we divided to the location, protected area and entire brain area were significantly lower in CP group. However, the secondary endpoint of MRI imaging after the 6 months, the number and volume of new cerebral region are no differences between both groups. And at 1 month clinical outcomes, stroke rate are not significant differences between both groups and no event disabling stroke. This is my conclusion. Prior to large randomized trial showed Sentinel CP device failed the reduction of short-term stroke rate. In this presented study, Sentinel CP device significantly reduced the imaging data. So, however, clinical stroke rate were not differences between both groups. So, further studies needed for the long-term clinical outcomes and neurocognitive dysfunction associated with the ischemic brain lesion. Thank you for your attention.
Thank you very much, Dr. Park. I think we can probably take one question, a couple of questions, if anyone has any comments. I mean, obviously, the most perhaps interesting aspect, I mean, the protective TAVR, I think that was the first study that actually, came counterintuitively to tell you that there were no major benefit. But I think that in your study, which is really interesting, there is this discrepancy between the acute and long-term presence of lesions. Is that because some of the initial lesions, for whatever reason, are transient and disappear, or is because there is an increase in lesions in the other in the patients that were not treated with TAVR, with protection? Do you understand how do you explain that there is a difference immediately after TAVR, but there is no difference in the long term, in MRI number of lesions?
Yes. I think the protected effect of the Sentinel device is short-term during the procedure, TAVR procedure. So long-term brain MRI will affect it to the patient characteristics, not to the TAVR procedure.
All right, but don't you think that the number of new lesions should increase evenly in both groups, and therefore that the initial difference should be kept?
Yes.
Understand? I think that's very interesting, but thank you very much. It's a great presentation. Thank you.
Then it's my pleasure to call the next speaker, Soo Yeon An, Enhanced Clinical Benefit of Preventive PCI of Vulnerable Coronary Plaques in Patient with Concomitant Non-Target PCI, a subgroup analysis of the PREVENT trial.
Thank you for your introduction. My name is Soo Yeon An. I'm a junior consultant at Seoul Asan Medical Center. This time I'm gonna present a pre-specified subgroup analysis of the PREVENT trial comparing outcome in patient with non-target vessel PCI to patient without non-target vessel PCI. I have nothing to disclose. Burnable plaques, often detected through intravascular imaging, are associated with high risk of adverse cardiovascular events. Burnable plaques can lead to myocardial infarction and sudden cardiac death, but the current guidelines recommend PCI only for flow-limiting lesion. But the benefit of treating non-flow limiting burnable plaque remain unclear. So our study's aim was to evaluate if preventive PCI in non-flow limiting burnable plaque can offer any benefit for high-risk patients with non-target vessel disease. So in the PREVENT trial, over 5,000 patients who underwent coronary angiography were evaluated with FFR for intermediate stenosis, and over 3,000 lesions with diameter stenosis more than 50% and FFR more than 0.80 evaluated with intracoronary imaging. A total of 1,606 patients were enrolled. Out of this, 576 patients underwent non-target vessel PCI before randomization. And then patients were allocated to either preventive PCI group for target vessel disease or the optimal medical treatment group. patients with non-target vessel PCI were at higher risk. They were more likely to have diabetes, hyperlipidemia, chronic kidney disease, and acute coronary syndrome and multivessel disease were more prevalent in this group. And in each subgroup, preventive PCI group was comparable to optimal medical treatment group. And preventive PCI group with non-target vessel PCI was more likely to have higher risk features such as high proportion of plaque burden or thin cat fibroatheroma detected by intravascular imaging. And in both subgroups, preventive PCI group had a higher percent degree stenosis, a lower minimal lumen diameter, and a longer lesion length. And patients with non-target vessel PCI typically require more extensive procedural time and resources compared to those without non-target vessel PCI. So the preventive PCI group demonstrated a reduction in primary composite endpoint, especially notable in patients with non-target vessel PCI. And this improvement was observed in both short-term and long-term follow-ups, suggesting the sustained benefit for this high-risk patient. For secondary outcome, we've looked at each component of primary composite outcome. While MACE rate and cardiac death and rehospitalization rate were comparable between two groups, target vessel revascularization rate was higher in optimal medical treatment group with non-target vessel PCI. Other indicators of secondary outcomes, including myocardial infarction, non-target vessel revascularization, stent thrombosis, stroke, major bleeding, were not statistically different between two groups. So to summarize, our findings suggest that preventive PCI following non-target vessel PCI improved both short-term and long-term outcomes. And patients with more extensive coronary disease can benefit the most from early interventional strategy. And a more targeted approach is needed when considering PCI in this high-risk population. Thank you for your attention.
Thank you very much, Dr. An. So we will keep the questions for the end of the session, and then we move then to the next speaker, that is Dr. Wee, talking about the impact of antithrombotic therapy modification, a post-hoc analysis of the EPIC-CAD CAD trial. Thank you.
Good morning, everyone. Today, I'd like to present a post-hoc analysis of the EPIC-CAD trial, which evaluates the efficacy and safety of the long-term antithrombotic therapy in patients with atrial fibrillation and stable coronary artery disease, with particular focus on the influence of prior antithrombotic therapy. I have nothing to disclose. And current practical guidelines, including AHA and ESC, recommend the NOAC monotherapy as the preferred long-term antithrombotic strategy for patients with AFib and either chronic or stabilized ACS who required oral anticoagulation. In EPIC-CAD trial, patients with AFib and stable CAD were randomized to receive either edoxaban monotherapy or a combination of edoxaban plus a single antiplatelet agent. The study demonstrated that your therapy significantly increased bleeding risk without improving ischemic outcomes, supporting NOAC monotherapy as a more optimal long-term approach. These findings were further supported by meta-analysis of major RCTs where monotherapy reduced major bleeding while maintaining similar ischemic event rates, reinforcing the principle that less is more in antithrombotic therapy. But despite this evidence, real-world clinical practice often lags behind. For example, I recently encountered an AFib patient who undergone CABG 3 years ago and still received rivaroxaban plus clopidogrel. Although guideline recommended this escalation seemed appropriate, I hesitate
upon discovering that the original regimen had been prescribed by a senior physician and found that it's very bad. So it's better to leave it alone, could appropriate for junior physician like me. Such clinical inertia rooted in difference to previous care decision and concerns about destabilizing a tolerated regimen frequently results in continued exposure to avoidable bleeding risks. And moreover, emerging data suggests that prior antithrombotic therapy may influence the efficacy and safety of the subsequent regimens. For instance, in pre-specified subgroup analysis of Oceanic AFib trial comparing Ascendesian with the EPIC-CAD, the benefit of Ascendesian was attenuated in patients who had previously received oral anticoagulants, whereas the outcomes were more favorable in the oral anticoagulant naive individuals. Similarly, the flail AFib trial, which aimed to evaluate the clinical effects of maintaining warfarin versus transitioning to NOAC in flail elderly patients with atrial fibrillation, demonstrated that switching from existing warfarin therapy to NOAC only increased the occurrence of the bleeding events without proportionally reducing the thromboembolic risk. In this context, this post-hoc analysis of EPIC-CAD trial tried to assess how prior antithrombotic therapy might influence the outcomes of edoxaban monotherapy versus dual antithrombotic therapy. And of the 1,040 participants in the trial, 970 patients had either been on prior oral anticoagulant monotherapy or dual antithrombotic therapy at baseline. To elaborate, among the entire EPIC-CAD patient population, we specifically focused on patients with prior mono anticoagulant therapy and those with prior dual antithrombotic therapy in order to eliminate the potential confound factors, which was total 88%. Following randomization, outcomes were compared in each arm among patients previously treated with monotherapy. 55% continue to monotherapy, and 45% were escalated to dual therapy. In prior dual therapy group, 45% were de-escalated to monotherapy, while the 55% continue to the dual therapy. The primary endpoint was a composite of the net adverse clinical events at 12 months after randomization, consistent with the main EPIC-CAD trial. At baseline, patients with prior dual therapy had higher ischemic and bleeding risk profiles with higher rates of current smoking and prior MI, PAD, PCI, and CABG. Consequently, their CHA2DS2-VASc score and Hassel-Bleed scores were higher compared to the prior monotherapy group, but it's as expected easily. However, after randomization into monotherapy and as shown in the current table, patients previously on monotherapy showed comparable baseline characteristics between the randomized monotherapy group and dual antithrombotic group. And similarly, among patients previously on dual antithrombotic therapy group, those randomized had almost similar background characteristics. Although the ischemic and bleeding risks were higher in patients previously on dual antithrombotic therapy when comparing patients previously on monotherapy group, the rates of net adverse cardiac events were similar regardless of prior antithrombotic therapy. While examining each group separately, in the prior dual antithrombotic therapy group, the incidence of the primary outcome was higher and evident in the the dual antithrombotic group after randomization compared to the monotherapy arm after randomization. It's the same in the prior monotherapy group. However, when compared with the prior monotherapy group, the p-value interaction was 0.39, so indicating no significant difference. For the major ischemic event, similar trends were observed regardless of prior antithrombotic therapy and post-randomization therapy. Regarding bleeding events, the prior dual antithrombotic therapy group, escalating to the monotherapy after randomization, evidently reduced bleeding events compared to maintaining dual antithrombotic therapy. However, when compared with the prior monotherapy group, the p-value for interaction was 0.28, so this was not a significant factor. In conclusion, transitioning from prior dual antithrombotic therapy to monotherapy maintained similar levels of ischemic event occurrence while significantly reducing bleeding risk. Conversely, escalating from prior monotherapy to dual antithrombotic therapy only increased the bleeding risk without apparent ischemic benefit. Thank you for listening.
Thank you very much. My pleasure to call the next speaker, Seung-Ho Lee, telling us, again, continuing with antithrombotic antiplatelets, antithrombotic therapy in diabetic patients with atrial fibrillation and stable coronary artery disease.
Thank you for introducing me. I'm Seung-Ho Lee from Asan Medical Center. Today I will presenting the post-hoc analysis of the EPIC-CAD trial. This study evaluates the efficacy and safety about of the Aortic-Valve monotherapy in patients with atrial fibrillation and cerebral coronary disease, even diabetes. The EPIC-CAD trial was published in NEJM in 2024. The trial showed that Aortic-Valve monotherapy was associated with a lower risk of NACE in patients with atrial fibrillation and cerebral coronary artery disease, and most of these findings were driven from the bleeding event. This is the design of the EPIC-CAD trial. About 1,000 patients with high-risk atrial fibrillation and stable coronary artery disease was enrolled and randomized by two groups, Aortic-Valve and monotherapy, and Aortic-Valve plus single antiplatelet therapy, 500 each. This trial evaluates the net adverse clinical events at 1 year following randomization. The composite outcome included both efficacy and safety. This is why we started this post-hoc analysis of the EPIC-CAD sub-study. Diabetes is a well-known risk factor of the coronary artery disease and atrial fibrillation. Also, it is a well-known risk factor of the stroke and bleeding event. So, in the real-world clinical practice, when we manage the high-risk patient with coronary artery disease and atrial fibrillation, even concomitant diabetes, we may face the therapeutic dilemma. When we intensify the medication, the bleeding event is our main concern. And on the other hand, when we reduce the medication, the ischemic event, we may face the high risk of the ischemic event. So the subgroup analysis assessed the efficacy and safety of Aortic-Valve monotherapy in patients with atrial fibrillation and coronary artery disease and even concomitant diabetes. In this trial, we defined the DM is by the documented medical history of the use of medications such as oral agent or insulin, the inclusion criteria and exclusion criteria, and the outcomes are the same as the original EPIC-CAD trial. The patient is not stratified by DM at the time of the randomization. So we use the IPTW used to adjust the baseline characteristics by Tuang method by 4 groups. The 4 groups included DM receiving monotherapy, DM receiving dual therapy, non-DM receiving monotherapy, and then non-DM receiving dual therapy. This is the baseline characteristics of the patient in the with or without diabetes. The total number of the diabetes patient is 421, and the non-diabetic patient is 619. The mean age is 72 years old, and then about 77% of the patient is male. Overall, there's no significant differences between the 2 groups, but in diabetic patients have more current smoker and previous KBG history. This is the adjusted baseline characteristics by 4 groups. The max SMD showed nearby 1.0 or nearby and below than 0.1. So this means that baseline characteristics are well adjusted by the adjustment. This is the study outcome in the patient with and without DM. There is no significant significant differences in the primary and secondary outcomes according to the DM diabetes status. This is the study outcomes for the patient with the 4 groups. NACE is more lower in edoxaban monotherapy groups, irrespective of diabetes status, and then it derived from the safety outcomes. And then efficacy outcome is there is no significant differences in the efficacy outcome according to the medication strategies. Let's see the Kaplan-Meier curve. NACE and ischemic event and the bleeding event. There is no significant differences according to the diabetic status, but as you can see, the diabetic patient have more lower bleeding event. But although it is not statistically significant, NACE is more lower in edoxaban monotherapy groups and irrespective of the diabetes status. There is no significant differences between the groups and according to the medication strategies. Bleeding event is more lower in edoxaban monotherapies, irrespective DM status. This is our summary. This is our study summarization. The instance of the primary net clinical outcomes at 1 year. It was lower in the edoxaban monotherapy group than in the dual therapy group, irrespective diabetes status. The instance of major scab event did not differ between the groups, between the patient with and without diabetes. Although the instance of major clinical relevant non-major bleeding was similar regardless of diabetes status, there was a trend toward a greater bleeding risk reduction effect among patients with diabetes receiving edoxaban monotherapy. As you see, in diabetic patient has lower rate in the bleeding event. This is the currently published in meta-analysis in JACC. Ischemic event, there was no significant differences in ischemic event according to the diabetes status. But in bleeding event, people who have diabetes has more effective in reducing the bleeding event. Actually, the diabetic patient is more vulnerable for bleeding events. So when we reduce the medication in diabetes, so the bleeding events may be reduced, but rare evidence maintains. So another further evaluation was needed. This is our conclusion. Edoxaban monotherapy was associated with the lower incidence of the composition outcome compared with the dual antithrombotic therapy, irrespective of diabetes status. These findings support the potential application of EPIC-CAD monotherapy in patients with atrial fibrillation and stable coronary artery disease, including those with diabetes. Thank you for listening.
Thank you very much, Dr. Lee. And then we go to the final presentation before we move to the discussion. It will be by Dr. Seo, optical coherence tomography guided or intravascular ultrasound guided PCI for in-stent restenosis lesions in the Octavus trial. Thank you, Dr. Seo.
Thank you for your kind introduction. I'm Kyung-won Seo from Asan Medical Center. Our study is the post-hoc analysis of Octavus trial to compare the clinical outcomes of CT-guided PCI or IVUS-guided PCI in ISL lesion. I have nothing to disclose. Intracoronary imaging plays a crucial role in PCI, particularly in treatment of complex coronary lesions. ACC/AH guidelines and ESC guidelines both recommended the use of IVUS or OCT in complex lesion. This recommendation was based on the results of multiple trials comparing the clinical outcomes of IVUS or intracoronary imaging guided PCI with angiography-guided PCI. Most of this trial demonstrate the superiority of intracoronary imaging guided PCI in complex lesion. The Octavus trial is the randomized control trial designed to compare the OCT-guided PCI with IVUS-guided PCI. The total of 2,008 patients were enrolled, and primary endpoint was target vessel failure at 1 year. The results show the non-inferiority of OCT-guided PCI. This is the history of the development in PCI techniques. From balloon angioplasty era to late generation DS, there was a substantial improvement in long-term outcomes, but these ISL still occur 1 to 2% per year. ISL is mostly results of excessive neointimal hyperplasia and neoatherosclerosis following stent implantation. Pathologic mechanisms of ISLs are heterogeneous. Anatomical factors such as vessel size, MLA, and severe calcifications, and clinical factors such as DMCKD, old age, female sex, and stent-related factors such as stent type, drug distribution, drug type, strut thickness, and procedural factors such as stent under suspension, stent metal position, and stent gap. Management of ISR is challenging because of its heterogeneous mechanisms and the relatively high rate of recurrence. So, intracoronary imaging modalities such as IVUS or OCT are essential tools to characterize the mechanism and substrate of ISR. But comparative data on the efficacy and safety of OCT versus IVUS in the treatment of ISR are limited. So we designed this study to compare the OCT versus IVUS in ISL lesion. This post-hoc analysis of Octavus trial included 164 patients with ISL and 87 patients assigned to a CT-guided group and 77 to IVUS-guided group. Median follow-up period was 1.7 years. The primary endpoint was composite of cardiac death, target vessel MI, and target vessel revascularization. And secondary endpoint was target lesion failure, death, target vessel MI, NEMI, and stent thrombosis, and stroke, and contrast-induced nephropathy. Octavus is not stratified by ISL at randomization, so the adjustment using inverse probability of treatment weighting. The baseline characteristics of two groups are well balanced between two groups, and there was no significant difference between two groups in anatomical or lesion characteristics. So the total amount of contrast dye used was higher in OCT group, and total PCI time was shorter in OCT group. And there was no IVUS or OCT procedure-related complications. This is the characteristics of the previously implanted stent in which ISL call. There was no significant differences between the two groups in stent type, stent size, stent length, and proportion of recurrent ISL. The primary endpoint was lower in OCT group, and hazard ratio was 0.34, and is mainly driven by target vessel revascularization. Secondary endpoint was target lesion failure and target lesion revascularization, and target vessel revascularization was lower in OCT group. After adjustment, the target vessel MI was also lower in OCT group. Kaplan-Meier curve shows the superiority of the OCT-guided PCI. So the treatment of ISL lesion requires detailed evaluation of stent strut, lumen area, and neointimal patterns. Given OCT's higher resolution and ability to delineate the composition of different plaque morphologies, OCT is superior to IVUS in assessing stent failure, so they can accurately identify stent under expansion or malposition, or detect thrombus and categorize the composition of the neointimal or neoatherosclerosis. Identifying the etiology of ISL has important implication for optimizing treatment and improving outcomes. In summarize, despite the continuation of advance of the DES technology, ISL remains a persistent clinical issue because the mechanism underlying ISL are heterogeneous. Treatment should be tailored according to the specific characteristics of each lesion. Intercoronary imaging plays a critical role in identifying the underlying pathology of ISL. In our study, OCT-guided PCI demonstrate the clinical outcomes compared to the IVUS-guided PCI. It may be because of OCT's higher resolution and ability to delineate the composition of different plaque morphologies. In my conclusion, in ISL lesion, OCT-guided PCI showed a significant reduction in primary composite event of death from cardiac causes and target vessel-related MI and target vessel revascularization as compared with IVUS-guided PCI. Thank you for your attention.
Thank you very much, Dr. Seo. Well, first of all, I think that we should congratulate again Asan Center for generating so much evidence, so many interesting studies. I think that this session is obviously based on research that is produced at Asan Center, and as always, it's very impressive to see the very important trials that are launched by the center and the excellent sub-analyses that are performed. So, Eveline, I would propose that we start in a sort of orderly fashion. We have first the presentation by Dr. Park about the cerebral embolic protection device. Perhaps, I don't know if there are any of the panelists, yourself, want to make any comment about this particular study. Any of you?
So just, thank you, Dr. Escaned. Can I ask just one question on that? In Dr. Park's practice in Asan, are there any specific patients you choose where you tend to use cerebral embolic protection based on your evidence, your practice?
Thank you for nice question. In Asan Medical Center, we choose the patient with high risk of embolization, such as high calcium volume, or bicuspid aortic-valve, or valve-in-valve TAVR, and need for the prevalent valvuloplasty patient.
Thank you. And sorry, what proportion of your patients would that be roughly? what percentage of your patients would qualify for
in
protection?
Korea, due to the insurance issue, so we can apply the device of the study patient. So in Sentinel Registry, total 150 patients is applied to the Sentinel device.
Thank you.
Do you have any comment?
Yeah, I'm always intrigued looking again and again at these counterintuitive results. One would expect that when applying a protection device to see a better outcome in the cohort with the device. Can you speculate, are we doing something wrong when placing the devices? Are we, as cardiologists, inducing the lesions that we then see later on MRI and that are, in most of the cases, obviously transient? Is there anything with the device or the way we place the device that could induce these embolic lesions?
I think recent trial failed the effect of the device on the stroke rate. However, this device can reduce the ischemic lesion volume and number. And in last year, published pooled analysis in JACC, volume of ischemic lesion less than 500 is reduced the stroke rate, and we consider the this point because of the TAVR indication of TAVR is extended to the low risk and younger age, and the life expectancy after the TAVR is longer. So these ischemic lesion can induce the neurocognitive dysfunction in long time. So I think we focused on this point.
Thank you.
I think that something else that is interesting, I mean, when you have so many trials trying to demonstrate a benefit, and you still keep thinking in the brain, when you see that you are not getting a benefit, perhaps you should start looking somewhere else. And my question is, how the time that you have to spend in doing this intervention is making the TAVR procedure longer. Is there any possibility that we are striving to protect the brain but not getting a benefit, but we are making the procedure longer, and therefore we may have also, so to speak, other type of events? Do you think, have you checked that there have been similar outcomes, procedural outcomes in TAVR with and without cerebral protection? For example, you might have, let's speculate, you might have more acute kidney failure, for example.
Yeah, but Javier, the acute results were in favor of the protection. Because this speculation would lead to more damage during the procedure. They had a benefit during the acute phase. It was not maintained after that.
Yeah, but I mean, we are looking to something that is cerebral in this particular case, but we don't know if this comes at an expense, for example, of an increase of immediate chronic kidney failure.
That may appear later, this disadvantage, you think?
Or, yeah, well, or periprocedural. I mean, that's something. I mean, the fact is that the net benefit for the patient is very low, because the patient rightly is concerned about a major stroke, that there is no difference whatsoever. So there is a surrogate image, that's something that you have to find with MRI, that disappears the difference at 6 months. Yeah. So from the perspective of the patient, honestly, I don't think that the study is supporting any benefit. Yeah. That's how I see it.
I don't think that this late disadvantage was created during the procedure.
No, simply demonstrates that the benefit is not durable.
Not there, yeah, sure.
As simple as that, yeah. So that's so you may prevent something that resolves spontaneously. Anyway, as you mentioned, more trials are needed, and perhaps focusing in patient-reported outcomes or cognitive tests that tell us if we are really bringing a benefit to the patient. So,
Can I
thank
ask
you very
one
much.
thing? So, your MRI result is the difference, the acute phase and the 6 months later. The MRI has actually improved that one. But do you think that result is coming from the NOAC or dual antiplatelet therapy for the management? Because of the NOAC, the treatment is the difference, the percentage. So how do you think about it?
In these characteristics, atrial fibrillation patient was more than in CP group, and so I think NOAC is less effect long-term follow-up MRI imaging.
So, thank you very much. I think that we can extend now the discussion to the second presentation. That was certainly very interesting. The Prevent trial. Eveline, do you have any comments that you would like to have to start the discussion?
No, I'm curious to know whether there was a significant interaction between the presence of prior non-target PCI and the treatment effect of preventive PCI. That means that you have seen more effect in those with non-target PCI from preventive, but was it an interaction there to say that preventive PCI works better for non-target vessel PCI patients?
Yes, there was definitely interaction, and this specific subgroup analysis showed that the preventive PCI seems to be more effective in patients with non-target vessel PCI. So those patients who have gone through multiple PCIs actually.
Should we reserve preventive PCI only to those patients?
Can you repeat the question again?
No,
Reserve the PCI?
No, it was such a bigger advantage in those with previous PCI that you have to say, let's reserve the preventive PCI only to those patients and not to the other without prior PCI. Not. So both benefited from preventive PCI, but the effect was more in those with previous PCI. This is the conclusion. I mean.
Yeah, but PCI was done at the same time with non-target vessel PCI and the target vessel PCI, but we excluded the patient who had previously had PCI in other lesion. So those are two different specific patient groups.
As far as I remember, that vulnerable plaque maybe means that MLA less than 4 square millimeter, plaque burden greater than 70%, and VH detected SIGPA, right?
Yes.
So I also enrolled the patients for Prevent trial, but frankly speaking, in my usual clinical practice, I don't put a stent for the physiologically insignificant lesion, even though there is a vulnerable plaque. In Asan Medical Center, do you put a stent? For example, FFR more than 0.8 and syncytial fibrosarcoma. Do you put a stent for those lesions?
It depends on the clinical circumstances. For ACS patient, it's a little bit different. If you saw the vulnerable plaque that has very rich lipid core and it looks very vulnerable on IVUS, then you want to put a stent in the lesion, right? But in our routine practice, we have many stable angina patients. We don't put stent just by looking at the IVUS images. And if FFR is less than more than 0.80, then we don't do stenting.
There's no difference between two groups in the use of high intensity statin.
Actually, we are conducting specific subgroup analysis for that matter because it's important to analyze the use of statin and the combination drug. But we haven't got the results yet. But it'd be interesting to see, like the medications and compare the result.
Yeah, I have a question. Thank you for your interesting data. I understand with PCI in non-culprit lesion group is multi-vessel disease, and without PCI non-culprit PCI group is single vessel disease. Multi-vessel disease patients have more risk factor, baseline patient risk factor, and single vessel lesion and patient is more less risk factor. So, what is our take-home message in this analysis? Number one is multi-vessel patients we will more aggressive complete revascularization. And number two is multi-vessel disease group is more risk factor, so we intensively medication and risk factor modification. What is? Please tell us your personal opinion. Number one or two, or both of them.
Also considering the results from the ischemia trial, I think this is my opinion for ACS patient, I think it's better to treat aggressively for multi-vessel diseases, but for stable patient, I don't think it's necessary to, go beyond than the current guideline directed therapy.
Dr. An, was any predefined sequence in performing non-target and preventive PCI? Let's say you have to finish first non-target and then to do preventive, or the other way around, or there was no determined sequence?
Yeah, the patient, it was pre-specified group, so we did non-target vessel PCI first, and then the patient were randomized to
That's why I said previous non-target PCI, yeah.
Very good. So thank you very much. We are going to move the discussion to the other topics because all of them are so interesting. So we move now to the EPIC-CAD trial. There were two presentations. We have the presentation by Dr. Wee. Any comments?
So I am curious also to know whether you stuck with the therapy they had before, for example, anticoagulation. Had they edoxaban before and they were still having edoxaban after the study? Or what was the anticoagulation before randomization?
Just the oral anticoagulation, regardless of the type of the NOAC or the warfarin.
Was any effect of the previous type of anticoagulation and previous type of antiplatelet therapy in the results?
I'm ongoing to analyze the depending on the type of the NOAC. So I think maybe next year I'll show you the results.
Okay.
So what about the dose difference after randomizations?
Dose difference.
Dose difference, right.
But if the patient with prior anticoagulant group with the lower the dose of the anticoagulation, they just do maintain the intensity of the anticoagulant. So I didn't consider that the factor as well, but I think in practical, it is of the practical trial. So many physicians think that the patient who took the lower dose of anticoagulant and then after randomization enrolled in the EPIC-CAD, they will just use the lower dose of the edoxaban, I think.
Very good. And there were also some, Dr. Lee presented also the outcomes in diabetic patients with atrial fibrillation that were allocated to either edoxaban monotherapy or a double antiplatelet treatment. That was also a very interesting study. Any comments from the colleagues?
Great information. Learn a lot from this, both the presentations on EPIC-CAD. A question for the speaker as well as for the panel. So, does anyone need antiplatelet in addition to the NOAC after 1 year of ACS or stent?
I think it depends on the PCI procedure, the may longer time or aggressive lesions, maybe it depends on that.
A bit longer. What about long term, beyond 2 years? Long term, is it adequate to have just NOAC for any patient with stable ischemic heart disease who has an indication for NOAC, AF or something?
But our study is just 1 year follow-up, so we should take the long-term, more long-term clinical outcomes. Yeah.
That sounds reasonable. Generally, from the panel, what do we think? I don't know, it's just nice to have some opinions.
So we are not giving antiplatelet therapy after 1 year, for sure, in all patients with coronary artery disease. And in many of them, we stop antiplatelet therapy after 6 months. So, and leave on single anticoagulation then after that.
Thank you.
So I'm very intrigued by the findings of both this analysis from EPIC-CAD. So in both these studies, patients with dual antithrombotic therapy and patients with diabetes, they had a higher ischemic risk. And despite that, they didn't benefit in ischemic outcomes from dual antithrombotic therapy.
Yes.
Any comment? Yes. So even in a diabetic patient, for example, they had higher ischemic risk. They had more bypasses. They have more CHAD was higher in them. Yes, right. And despite that, dual antithrombotic therapy, that means edoxaban plus antiplatelet therapy, was not associated with the benefit in ischemic outcomes, but only decreased bleeding.
Yes. Our study sustained the main value of that ischemic event. There was no significant lesions, but I am going the sub-analysis of the patient. So we'll check that point. Okay, thank you.
Diabetic patients are more sensitive to bleeding than to ischemic complications.
I think it's more important is the bleeding event. So because previous studies showed that bleeding event was more associated with mortality. So I think bleeding event is more important.
Yeah, probably has to do with the patients that were included in the study, obviously. So if we want to discuss the last presentation, which is very nice, we will move forward. It was done by Dr. Seo, and very interesting sub-analysis of the Octavus trial suggesting that you get better outcomes when you're using OCT than IVUS in stent restenosis, and you speculated that is probably because you have a higher definition, you understand better what are the contributions to stent failure, etc. So, Eveline, this is your field as well, and Dr. Kubo probably could also comment as well.
I have a question. Are there any difference in the procedure, including lesion preparation, device sizing, and optimization between the groups?
Thank you for
final treatment of DS or DCB. Are there any?
Thank you for your insightful questions. And there was no significant PCI modality and the balloon inflate or stent size, length. There was no significant differences between two groups.
Were the acute results comparable between both? Okay. Irrespective of IVUS or OCT? Did you look at the acute results? Was the acute result better for the OCT group than for the IVUS?
Minimal stent area, etc.
Yeah, there is data exists, but the analyzed we will address the point in further future study. So I will show you the next.
I think that would be very interesting because if you are really trying to make a sort of mechanistic explanation of the clinical benefit. Probably it should be mediated by the fact that you have achieved, a better result. But congratulations. Well, congratulations, I believe, to all the speakers and the researchers for the work that we've done. I think that we have reached the end of the session, Eveline. So thank you very much, and we wish you a very enjoyable rest of the Congress. Thank you.